Hello everyone. Now I'll be discussing question of cardiology. So we have a 80-year-old lady. She is a very elderly lady. She has sudden onset of epigastric pain. Come to emergency. Pain started an hour ago and was very severe. She has nausea and vomiting twice in the past 1 hour. She is a known case of diabetes, hyperlipidemia, hypertension, peptic ulcer. For the last 10 years ago, she had peptic ulcer also. And cholelithiasis is there. 40 pack year smoking history is also there. Occasionally drinks alcohol. BP at the moment is fairly normal. Pulse is again in the normal range. Respiratory rate is normal. Lungs are clear on auscultation. Abdominal examination shows a soft abdomen with no tenderness. Murphy's sign is negative. That clearly rules out appendicitis. Now, which of the following studies should be first to be done in this patient? Answer is electrocardiogram, that is ECG. Something very interesting to talk about. Why this answer? Why not others? Okay. Well, there are many risk factors in this patient, right? And ECG should always be done as a first investigation. Risk factor for CAD, which can consistent with acute coronary syndrome. Now, one more thing, not only remember in this the patient problem is main epigastric pain, not the pain chest. And this is so-called atypical presentation. Atypical presentation means no overt pain chest. We know very well that in acute coronary syndrome, severe pain chest is there with sweating and palpitation also. But not in every case of coronary syndrome, pain chest will be there. So there can be acute coronary syndrome without pain chest also. This so-called atypical presentation is there. Okay. Well, that again should be prompt a cardiac evaluation. Now, majority of time, like in this case, patient has epigastric pain. If the treating physician is not careful, he will never think about coronary. So that's why there is a delay in diagnosis and under treatment, which could worsen the outcome. Definitely, the patient has acute coronary syndrome, not taken care. It carries a very high mortality. Now, what are the atypical symptoms that we are talking about? Okay, like in this case, it is more common in females, elderly, and our patient is a 80-year female, patient with diabetes. And in fact, our patient is an elderly lady of diabetes, so she has all the three conditions where the atypical pain, atypical coronary presentation is there. So, and up to 20% of these patients do not respond pain chest at the time of presentation, so-called atypical presentation. So, what are the common atypical presentation? Patient may have dyspnea, epigastric pain, nausea, vomiting. In our patient, they have these two. In addition to that, patient can have palpitation, sweating also. There are other things that can be there in as an atypical presentation. So now let us see what are the relative frequency of some feature of acute coronary syndrome. Pain chest in 80 to 85%. This means about 10 to 15 to 20% patient, or maybe 10 to 20% patient may not have pain chest, and they may come with these findings, which are known as atypical finding. Atypical finding means without any pain chest. There could be dyspnea, nausea, vomiting, epigastric pain, palpitation, sweating, syncope can be there. So now we have patient is there. We know very well the patient has a risk factor for CAD. Okay. Now abdominal ultrasound. This we do to diagnose acute cholecystitis. Serum amylase level, that we do to rule out acute pancreatitis. Upper GI endoscopy, this we do to rule out any acute GI blood loss or evaluation of possible of peptic ulcer disease. Okay. Well, do we need to do all this? Yes, they are to be done, but not as the first. Why so? Patient having epigastric pain and where the risk factors are there. Out of all these, pancreatitis, cholecystitis, peptic ulcer, none of them can lead to immediate mortality, except coronary. There's a reason. That's why the first investigation is always ECG. Okay, so all they may need to be considered in this patient. Remember, what I mentioned, we talk, the possibility is there, but less immediately, less life-threatening. So always rule out cardiac pathology first. And echo is not the first investigation for CAD. Even we are thinking in terms of coronary syndrome, echo is not the first investigation. So golden line to remember, abdominal pain and nausea, vomiting are the atypical presentation of acute coronary syndrome. In select patient, cardiac cause must be excluded prior to pursuing other etiologies. Thank you very much.